management will be in subsequent talks moving forward. There we go. So disclosures, I have no financial disclosures. I am a woman with many, many hats on the physician realm of things. I am a private practice nephrologist with a group in Metro Detroit called St. Clair Nephrology. I'm the program director of the Nephrology Fellowship at Henry Ford St. John Hospital in Detroit. And as Mary has already mentioned, I am on the scientific advisory board and the board of directors for National Kidney Foundation of Michigan. So what our plans to go through today is really identify what are the risk factors in populations that need screening for chronic kidney disease, and what are some of the guidelines that we use to help accomplish that. What are the testing that we use in understanding diagnosis and then risk and prevalence within the state of Michigan. So I always like to start off with a case. A 42-year-old female has a history of high blood pressure and diabetes. You get labs, creatinine is 1.25, and the urine albumin to creatinine ratio is 985. And really, what do we do with that information? What does that mean? Does this have patient have CKD, and what's their risk? And the goal is by the end of this talk today that you'll be able to identify and risk stratify this patient. So what is chronic kidney disease? So it's a loss of kidney function over time. And I think the over time is an extremely important part. We have people that have acute kidney injury or acute renal failure all the time in the clinics or in the hospital, but that resolves and gets better. But chronic kidney disease is a chronic illness that can be from multiple different factors that's often, no symptoms. And we don't have a cure for chronic kidney disease that once you have it, you're diagnosed with it. We say that you've had an abnormal GFR or protein in the urine, which we'll discuss for over 3 months. But we can slow the progression. And there's lots of data that shows that early intervention in these patients can slow the progression by 30 to 50%. And that the goal is try to prevent people from reaching end-stage renal disease, which is, kidney failure requiring dialysis or a kidney transplant. So we have to understand that kidney disease is common, it's greatly underrecognized, and it can be deadly. So if we talk about how common kidney disease is, according to the CDC, more than 1 in 7 people in the United States, or 15% of US adults, are estimated to have chronic kidney disease. So that's about 37 million people. And the scary part with this is not just that number, but it's the amount of people that don't know that they have it. So 90% of people that have stage 1 through stage 5 don't know that they have it. And even in the severe stages of kidney disease, stage 4 and stage 5, over 40% of them don't know that they have chronic kidney disease. So if we look at this more pictorially to really understand the weight of the amount of people that is, any Michigan fans out there, I know this is a MSU COM talk, but the big households are just over 100,000 people. And so if you have each one of these boxes represent over 100,000 people, this is chronic kidney disease in America. These are the 37 million people that have chronic kidney disease. In only about 700,000 of those patients, about 500,000 are on dialysis, and about 200,000 have kidney transplants. The rest are all stage 5, not on dialysis or above. And so I show this slide to really explain that most of the care of kidney disease patients isn't in the hands of the nephrologist. They're seen by primary care doctors, cardiologists, and so it's really important that all physicians and care providers understand the importance of identifying and caring for these patients. So if we look at in Michigan, and this is data that has been made available by the National Kidney Foundation and through grants of what's the prevalence of chronic kidney disease. And it's high. In Medicaid patients, about 8.3 have been diagnosed with chronic kidney disease. And in Medicare patients, obviously, those are older individuals, about 26% have been diagnosed with CKD. And how this map works here on the right is the darker the color, the more prevalence of disease that there are. But these numbers are likely underestimated because you have to be screened. And for example, in northern Michigan and other parts in underserved areas, they may not have been screened at all with a creatinine to calculate a GFR or an ACR. And so these numbers may even be higher than what we have now. And if you look at the prevalence by diagnosis of CKD. So the blue bars are the prevalence of how many people have chronic kidney disease. And then the orange bars are who actually have an ICD-10 diagnosis of chronic kidney disease. And obviously, there's a big discrepancy between that. But even at the later stages, so 4 and stage 5, 50% of the people that have a prevalence of CKD 4 or 5, only about half carry the diagnosis. And so if they aren't diagnosed, how are they getting treatment to prevent progression? And you say, well, not that many are that sick. So, what is what's the big drop off? Not that many people are progressing. You have to understand that about the drop off isn't because people aren't progressing. It's that the most risk to these patients is cardiovascular disease, and that you have about a 30 times greater risk of progressing to cardiovascular mortality than you do to ever reaching dialysis or transplant. And so people are dying with CKD from cardiovascular mortality instead of from CKD. But the worse chronic kidney disease you have, the higher the risk of utilization, hospitalization, cost, and mortality. And so basically with each stage, the cost of caring for that patient is doubled. So if you took, for example, CKD 2, about $15,000 per year to care for that diagnosis. Stage 3 is about $30,000 or 75. And once you're on dialysis or stage 5, oftentimes it can cost much over $150,000 per year to care for these patients. But again, to my point, very small number of chronic kidney disease are progressing to stage 5, but more in these stage 3 and 4, even still carrying a greater cost and mortality risk and having to identify these individuals. So let's talk about how deadly it is then, or how fatal. So when they look at mortality in the United States, kidney disease is currently the 9th leading cause of death in the US. They project that by 2040, this could be increased to the 5th leading cause of death. And so it's something that we have to be in tune to identify and try to prevent. And this isn't just worrying about dialysis and transplant. When they look at cardiovascular mortality, so heart attacks, strokes, having a low GFR, so less than 60, or an albumin creatinine ratio above that 30 range, or a combination of the two, has the highest predictor of mortality in patients. So that's more than smoking, more than being a diabetic. Having the diagnosis of CKD by one of the diagnostic criteria increases your cardiovascular mortality. And this has really become evident because of kind of the interplay that all of these have, that having albuminuria is just really a snapshot of the inflammatory changes that are happening within the kidney, in the fibrosis and scarring and hardening of the vessels that happen. And all of those things then lead to the heart disease that causes death, like heart attacks, arrhythmias, strokes, higher blood pressure, which then increases your stroke and heart disease risk more. And so the interplay is extremely important. And it's not now just gotten the attention of nephrologists, but cardiologists as well. So much so there is online calculators to calculate cardiovascular risk, the most common being this American Heart Association Prevent online calculator. You can either Google this, or you can get it on apps on your phone. But you can see that urine albumin to creatinine ratio and GFR are now both part of that risk calculator. And when they talk about this cardiovascular kidney metabolic syndrome, that it's not just the heart or metabolic syndrome like we learned when I was in medical school, but really the importance of the interplay of kidney disease as well, and the risk factors that having not even high, stage 4 or 5, but early stage 3 chronic kidney disease and its risk to the heart and overall cardiovascular mortality. And, it just keeps coming up more and more, not just in nephrology literature and guidelines, but cardiology as well. So this is a snapshot of the most recent American Heart Association hypertension guidelines through ACC and AHA. And you can see that number 3, as far as screening and routine testing for someone with blood pressure, now includes this urine albumin creatinine ratio or urine protein to creatinine ratio, which we'll talk a little bit about what's the difference as we move forward with this talk. So again, really putting a spotlight on how important it is to identify kidney disease as a risk factor, in not just identifying people with high blood pressure, but really risk stratifying these patients and taking care of them, not in a one size fits all, but if you have hypertension with a normal GFR and normal ACR, your cardiovascular risk is much, much less than someone that has hypertension with these diagnostic criteria of CKD. So if we look at then how do we identify people that may be at risk for CKD? So diabetes is the number one cause of chronic kidney disease in the United States. You would expect then, if we know that that's the number one cause of kidney disease, that all diabetics would then be screened for chronic kidney disease by either urine ACR or GFR or both. And sadly, that's not the case. Only about half of Medicare patients are screened each year for chronic kidney disease that are diabetics, and only about 22% of diabetic medicated patients get screened each year. So you have these people that are very high risk populations. We know they have one of the number one risk factors for end-stage kidney disease in the United States, and we're still doing a very poor job at screening them for kidney disease. So again, 90% of people don't know they have chronic kidney disease. Even in later stage, about half of them don't know they have chronic kidney disease, and only about half are getting screened if they're diabetic. And it's even worse for other disease states. So another common cause of end-stage kidney disease in the United States is high blood pressure, and only about 7% of people with high blood pressures get screened yearly for chronic kidney disease by way of GFR and urine albumin to creatinine ratio. And even if they have evidence of chronic kidney disease, 90% of diabetics who come in, you have diabetes, you have either an albumin to creatinine ratio that shows signs of albuminuria, or you have a GFR less than 60, still don't have a diagnosis of CKD in their chart. So again, if you don't have a diagnosis, you're less likely to be flagged for identifying those risk factors and then doing what you need to do to prevent progression of disease. So how do we screen these people? How do we look for and identify those individuals that could have chronic kidney disease? So most of us are all familiar with creatinine. Creatinine is a muscle breakdown product that's filtered through the kidney, and we urinate it out. So the higher the level in the blood, the less the kidney is filtering. And we put it into an equation to calculate a GFR or glomerular filtration rate. It's not perfect, though. We have problems with this as a way to diagnose. And so they started coming up with combination and what other molecule could we use to measure the GFR or a surrogate for GFR. And there was something called cystatin C. So if we consider the creatinine kind of the old Model T, the tried and true, and then cystatin C, sort of the Tesla model or newer agent, which one is better? Well, neither one is perfect, right? So both are freely filtered, which you want that to happen. You want to have something that's easily filtered through the kidney if what you're trying to calculation is a filtration rate of the kidney. Neither of them are reabsorbed, meaning that once it is in the tubular lumen and about to, be in the urinary space, the kidney is not absorbing that, which is not the case for certain drugs and other molecules. Not secreted, because that can falsely estimate the GFR. Unfortunately, creatinine is secreted by our tubules a little bit. And so if more is ending up in the urine, that is going to flaw our GFR in somewhat. That's not the case with cystatin C. Not affected by muscle mass, right? Creatinine is. And so if you have a very muscular individual, it could look like they have a higher level of creatinine in the blood that would falsely drop their GFR. And so that's where then cystatin C in these extremely muscular individuals, bodybuilders, using that as a measure of their filtration number and kidney function is important. And then not affected by other causes of other health issues outside of kidney disease. Creatinine is not, unfortunately, cystatin C is. For example, if you're obese or you're on steroids, these can be examples of something that can affect that cystatin C number. And so they recommend using one or the other or a combination. Creatinine is far less expensive to to order as a lab test. Not all labs have cystatin C available. And so for the most part, we primarily rely on creatinine. But there are sometimes that cystatin C is helpful. For example, in patients that have liver disease or have an elevated bilirubin, oftentimes that interferes with the measurement of creatinine on the testing that we use. And so cystatin C becomes helpful. The other thing is looking at the GFR difference. So most of them should be fairly similar. If you have a very negative difference, meaning that the cystatin C is much lower GFR than the GFR by creatinine, that could portend some poorer prognosis from a cardiovascular perspective. So I think that we will have more information and more data about this as we move forward, but just understand that there can be a variety of this. But at the end of this, all you need to know is you need to check a GFR. Most of the time is by way of creatinine. So how do they calculate it? You would never need to memorize the calculation. There's lots of calculators that are able to be used. Most hospitals and labs now use the CKD epi equation that has taken race out of the variable. So you just need that blood test, the patient's age, and whether they're male or female, and that calculates the GFR. Again, you can have, if you had both numbers, you could get an even more accurate, but it is not necessary to have the cystatin C to measure GFR. A serum creatinine is more than adequate. So why did they take race out of GFR? So this happened about 5 or so years ago. You may have remembered when you ordered lab tests, there used to be a GFR-A, which was for African Americans, and GFR-C for Caucasians, and they were slightly different. And the idea behind that was when they initially did the older equations for calculating GFR, MDRD, and CKD-epi, the Black patients tend to have greater muscle mass, so they corrected for this. But the problem is race and ethnicity are social constructs and not biologic construct. And for no pun intended, our human race is a melting pot, and it's not just black and white. And there's a lot of in between. And the problem is you have someone that has the greatest risk of kidney disease, Black individuals with genetic mutations like APOL1, that you were falsely reassured that they had a higher GFR, and it really affected how you screened them. So for example, if you had the same 50-year-old female with a creatinine of 2.1 and they were Black, they had stage CKD 3B, as opposed if they were not Black, the GFR would be 26 or stage 4. Most individuals in primary care get nervous with that stage 4 diagnosis and were likely to refer when that GFR fell less than 30. And again, this individual may actually have higher risk for progression, and that could be problematic for that patient moving forward. Same thing for kidney transplant. If you had the same 50-year-old female, their creatinine was now 3. If they were a Black patient, the GFR would have been 21, not Black, 18. You can be listed and accrue time for a kidney transplant once that GFR falls less than 20. So again, not getting the appropriate care for patients in a timely manner. And so they've taken race out of the equation, and it's just the CKD epi modified for without race. Labs in the outpatient side will all calculate this for you. You'll always see it on the lab, and it's important to look and identify that. So what are the KDIGO, which is a great resource if you're ever looking for kidney disease guidelines, whether it's blood pressure management, anemia management, glomerular nephritis. It's just kdigo.org. And they really give the guidelines of what you should do for these patients. So first is that you should screen patients either by GFR with creatinine or the combination with the creatinine cystatin C. Either is fine. And then based on that is trying to evaluate the cause. If you don't know the cause and they have need for nephrology referral, then we would maybe consider either genetic testing or kidney biopsy to understand what's going on with the patient. So what are some risk factors for chronic kidney disease? There's modifiable and non-modifiable risk factors. Diabetes and high blood pressure are the two most common cause of kidney disease and end-stage kidney disease in the United States. Now there are genetic predispositions to becoming diabetic and having high blood pressure, but obviously the rate at which they're controlled is definitely a modifiable risk factor. Frequent NSAID use, if people are using a lot of Motrin, ibuprofen, Aleve, those can cause inflammatory changes in the kidney over time, being overweight, and smoking. So obviously, talking with our patients as far as appropriate exercise, nutrition, low salt diet for blood pressure control, medication compliance for our diabetes and high blood pressure, and out of scope this talk, but all of the right medications that they should be on for those disease states. And then there's lots of non-modifiable risk factors. So family history, asking your patients, do you have anyone in your family that was ever on dialysis or got a kidney transplant? Older age individuals. So the older we get, the higher likelihood of kidney disease because of that thickening of the blood vessels and stiffness that happens to our arteries over time. Different races and ethnicities have higher risk of kidney disease. And so understanding family history, but also where patients are from may have genetic variability and even geographic exposure. So for example, people that work in very hot climates can have a higher risk of interstitial nephritis if on certain areas where they might be exposed to things in the soil that can lead to kidney disease and uroepithelial malignancies. All understanding where the patients are originally from, where they live now. Family history is all extremely important when you're taking your medical history. Frequent AKI. So did they have a severe sepsis episode where they were on dialysis at one point in time? The best predictor of them going on to chronic kidney disease is a ACR at 90 days after that episode of AKI. If a young female had preeclampsia in one of her pregnancies, it increases her risk for chronic kidney disease later in life. And then systemic diseases, lupus, malignancies, HIV, hepatitis, other autoimmune diseases like Sjogren's or rheumatoid arthritis, all can have an interplay with kidney disease as well. And as new drugs come out, not just for kidney disease, but cancers and other health conditions, all of those are often filtered through the kidney. And so there's risk for drug-induced injury as well. And so a medication history is extremely important as well. So what is a urine albumin to creatinine ratio? It's really allowing us a snapshot into the kidney. And it's just that. It's a ratio of urine albumin over a urine creatinine. And so it's not perfect, right? If someone has an episode of AKI and their creatinine is up in the blood, the urine is going to have less creatinine in it during that injury and can falsely elevate that albumin to creatinine ratio. And so you want to be doing that in not an acute injury, but in a chronic steady state. Ideally, you want to use the first void urine of the day. There's less chance of albuminuria at that time. Albumin is a big molecule, and so it should not end up in the urine. We do have some tubular secretion that happens. So if you ordered a urine protein to creatinine ratio, which would be all proteins in the urine, you could see that number be a little bit higher because in times of stress, infection, fever, vigorous exercise, you can slough off some of the natural proteins of our tubular lumens in our kidney into the urine, and those would be acceptable. Also, other disease states like, for example, amyloidosis or myeloma, where you have these light chain proteins that end up in the urine, would not necessarily change the albumin to creatinine ratio, but if you got a protein creatinine ratio, it would falsely elevate those. So when we're talking about screening for chronic kidney disease, the best test to get would be the urine albumin to creatinine ratio, again, because we shouldn't expect albumin into the urine. And we really classify these now into normal or mild, which would be A1, which I'll show a chart for that, moderate A2, or severe A3. We used to use a term called microalbuminuria that was in that what used to be A2, so 30 to 300 range. That term has gone away, but some labs and ordering sets still have not gotten rid of that. So just understand whether you order a microalbumin to creatinine ratio or a urine albumin to creatinine ratio, you're getting the same thing. And again, the nice thing is you don't need a 24-hour urine to do this. You can just do one spot specimen. So why do we care about this? So I'm going to start here on the top first. This was NHANES data where they looked at 10,000 diabetics, and they said, what is the risk of cardiovascular death if they had no kidney disease? So meaning their GFR was above 60 and their urine albumin creatinine ratio was less than 30. At 10 years, that risk was 4.1%. If you had albuminuria, meaning that you had a normal GFR above 60, but an albumin creatinine ratio of less than 30, you had about an 18% cardiovascular mortality at 10 years. If you fast forward then to having a combination of albuminuria, so greater than that 30 to 300, but also a GFR less than 60, you had a 47% chance of death in 10 years. So basically a 10 time greater risk, over 10 times greater risk of death with having albumin and impaired GFR. And this is just showing you kind of what I talked about on the other slide, whether you're ordering a urine albumin to creatinine ratio or a urine protein to creatinine ratio, you should be able to identify risk. So the more protein that you're spilling in the urine, the higher risk of going on to ESRD as well. So protein is a good indicator of not just cardiovascular mortality, but as well risk of progression to end-stage kidney disease. So all patients should be screened yearly if they have high blood pressure, if they're overweight, if they're diabetic, family history, already have chronic kidney disease, and the way to do that is by the ACR and GFR. So if you're eating your lunch, taking a nap, whatever the case may be, if this is the only slide that you remember for this entire talk, is the importance of annual estimated GFR reporting, which is a blood test with combination of the urine albumin to creatinine ratio spot specimen. And if you like an algorithm of how to do this, this is, again, from the KDIGO guidelines. So you want to identify those individuals at risk, like we have already mentioned, testing for the markers. If their GFR is less than 60, you want to make sure you're excluding any acute injury. Maybe they were taking a drug, maybe they were hypotensive or volume depleted. And then from there, repeating the test. If it has maintained for over a 3-month period of time, then you would give the diagnosis of chronic kidney disease. If it had been resolved, this was really probably either a lab area or AKI, they don't have chronic kidney disease. But you can look at all these algorithms and work through them with any patient when you're looking at their blood work. So again, I think most people are comfortable with the GFR reporting. So G1 is people with a GFR above 90, but have some kidney disease by either way of proteinuria, or they only have one kidney, or they have hematuria, cysts. Stage 2 is 60 to 89. We, within the last 10 years, have split up CKD stage 3A and 3B, understanding that there is a little bit of difference in risk in these individuals. So 45 to 59, 30 to 44. Stage 4 is that 15 to 29, and then stage 5 is a GFR less than 15. But this only tells part of the story. And really getting that albumin amount in that spot specimen by ACR is extremely important as well. And it really does help you risk stratify these individuals. So if I have stage 3A, meaning that my GFR is 46, but I have an albumin creatinine ratio of 20 or no albuminuria, I actually have a better prognosis and just need to be screened once a year, as opposed to someone that might have a normal GFR of 95, but has 400 milligrams of proteinuria. That should actually be checked more frequently and have a much higher risk of progression of ESRD and cardiovascular mortality. And so this heat map is also part of the KDIGO guidelines that really just helps say when you should be looking at these people. So, anyone that has a GFR less than 60 or albumin to creatinine ratio above 30 should have some type of treatment regimen to try to slow that progression. And anyone in one of the red areas should likely be screened by a nephrologist and seen as well, and be seen, more frequently, 3 to 4 times per year. So again, just to reiterate, this is an abnormal kidney function for at least 3 months, and that's by way of a GFR less than 60 with some other marker of kidney damage, whether it's an ACR or hematuria, only having one kidney, stones, history of kidney transplant are all within the realm of having the diagnostic criteria of CKD. So let's look at this then from a case perspective. So if you had a 55-year-old obese male with a history of high blood pressure, and he takes a diuretic and ACE inhibitor at home, he had an episode of acute kidney injury due to NSAID use about 6 months ago, and now he's back for follow-up. During his AKI, his GFR was greater than 90. His prior ACR had no albuminuria. And again, remember I said that anyone with AKI, the best predictor of chronic kidney disease is doing a 90-day GFR and ACR for risk of progression, which they did since it's over 6 months. Now his GFR is stabilized at 65, and he has a persistent albuminuria of 150 milligrams per gram. And so the question is, how should this patient be classified? What is his risk of progression and how should he be monitored? So if you go back to this, we said his GFR was 65, so he would be in G2, but he also had 150 milligrams of albuminuria, so it's A2, so he would be in this G2 A2 category, meaning that he should be treated with something for the proteinuria. He's already on an ACE inhibitor, which is great. Consideration to add an SGLT2, which is out of the scope of this talk, but also should be followed at least yearly for following that GFR and ACR number. Let's compare this to a different individual. Younger person, younger doesn't always mean better, and healthier kidneys. This is a type 1 diabetic. Like we said, that's diabetes is the #1 cause of kidney disease leading to dialysis in the United States. Also has hypertension and dyslipidemia. She's on an ACE inhibitor with good blood pressure control. We hope that means it's 120/80 because that's our target is less than 120/80 now on the basic new guidelines for high blood pressure. And within the past 3 years, her GFR has dropped from 46 now to 28. And her current albuminuria consistently remains above 300 milligrams per gram. So how would this patient be classified? What is her risk of progression and how should she be monitored? So again, if we look at that heat map, her GFR was less than 30, so she's G4, and her albuminuria is greater than 300, so that makes her a G4A3. She's in one of the highest risk of progression of kidney disease, and this should be monitored by lab work at least 4 times a year and really focusing on goal-directed management, which again is a different talk for a different day on how you manage this patient. And why would you want to refer these people to nephrology is so that you can develop these relationships. #1, for education. The more education we can give individuals, the better likelihood they are going to choose a home modality for dialysis, prepared with the appropriate access for dialysis, as well as be listed for kidney transplant. You can be listed for a transplant when the GFR is less than 20. And if you're getting listed right at that cutoff of 20, the hope is that you may potentially get a preemptive kidney transplant one day because the average wait time in Michigan is about 5 to 6 years. And so we don't want to wait till that GFR is less than 10 to get them ready for dialysis and kidney transplant, but very much earlier on upstream to get the best outcomes for our patient. And unfortunately, a lot of times patients aren't referred quickly enough. So in Michigan, less than half of patients with kidney disease have seen a nephrologist prior to starting dialysis. And so you can imagine if someone is coming to see me and the very first time that they're meeting me, I talk to them about starting dialysis. 1, they're not going to be very happy. 2, it's going to be way more anxiety provoking for that individual. And 3, they might not come back because they don't like what I have to say. And so if we can develop that relationship and rapport with the patient and are able to educate them over time, the data does show with early education in a multidisciplinary approach, they are more likely to get listed for transplant. They are more likely to have better outcomes and more likely to have either the right access or right modality. For example, 90% of patients, over 80% of patients in the United States start in-center hemodialysis with a tunneled central venous catheter, or what we call a perm cath. Those have the highest risk of mortality and infection. And if we have patients that we're seeing earlier and educate sooner, we can really avoid the biggest mortality effector of patients when they're starting dialysis. So when should a primary care doctor refer to a nephrologist? So let's go back to this patient. So she's a 42-year-old, high blood pressure and diabetes. Her creatinine, if we put it into the GFR, is less than 60, and her ACR is 985 milligrams, which would be the A3. So she would fit into one of those red box categories that she should be referred to nephrology for follow-up. But here's a more complete list. So GFR less than 30 definitely should be referred if they have an unexplained progressive decline. So on average, patients should lose about 1 to 2 mLs per minute per year. And that's considered acceptable age-related decline. That's not a true thing, but it's considered acceptable. If people are losing 5 mLs per minute per year, so in 2023, their GFR is 50, and then in 2024, their GFR is 45, and in 2025, their GFR is 40, and in 2026, now it's 35. That is problematic, and you shouldn't see that steep of a decline in their GFR and should be referred. If you don't know the cause, if someone has kidney disease, but you really don't have these common risk factors of high blood pressure, diabetes, it's important that they are referred. If they have rare hereditary or genetic conditions, because sometimes there are studies that we can enroll these patients in for better treatments for preventing progression. We can do genetic testing on these patients to identify those that are at risk, and are just better equipped at managing and getting better insight to these rare conditions to treat patients, perhaps not even necessarily that particular patient, but their family members and patients down the line. Significant albumin or proteinuria. So they might have a normal GFR, but if they have a gram of proteinuria, they should be referred. People that have persistent microscopic hematuria, managing the CKD complications like anemia, hyperphosphatemia, other vasculitic and hematologic disorders, or other electrolyte imbalances as well. Persistent hypo or hyperkalemia, hypermagnesemia, hypocalcemia, recurrent kidney stones. We can sometimes look and find metabolic causes for that. Anyone that is pregnant with chronic kidney disease should be followed with a nephrologist during that pregnancy, because not only is there an increased risk of harm to the mother with maternal complications like preeclampsia and cardiovascular mortality, but also risk of preterm delivery and small for gestational age babies. And then also if they have a higher risk of, above that 3 to 5% 5-year risk on the kidney failure risk equation, which we'll go over. Just a little brief talk about genetic testing in kidney disease. This is something newer that there are now kidney-specific genetic testing that can be done that is helpful in identifying those with kidney disease. And so this isn't necessarily the clean-cut high blood pressure or diabetic patients, but if someone has kidney disease at a very young age or multiple family members that have gone on to dialysis, or you see these cystic changes on the kidney, we do now know genetic mutations that can cause this. And when they look at this, it's extremely helpful in finding a diagnostic yield. And there's been a lot of data that's come out recently where perhaps you had some individuals that you didn't know the cause of their kidney disease, that about 20% of the time they can be reclassified and also perhaps even change the management of that patient. And these are readily available through nephrology practices to identify those individuals. And the good thing about it is we may not have a treatment for certain genetic mutations now, but in the future, when we have these genetic mutations, we can pull these patients together, and it allows for more research and data to be obtained to help prevent progression of kidney disease for individuals in the future. So I talked about that kidney failure risk equation. So this is something that is available for everyone. The website you can go to is kidneyfailurerisk.com. There's also an app you can get on your phone. And it really gives you not just the risk, but then can help give you a plan. So for example, if I had a 65-year-old female with a GFR of 38, and all as I did was change the albumin to creatinine ratio. So I had someone with A1 or 17 milligrams per gram, and then I have A3 with significant nephrotic range proteinuria, 5,000 milligrams per gram, and I kept all their labs the same. You can see on the left-hand side, this is that 65 with a GFR of 38 and no proteinuria. The risk of her going on to dialysis in the next 5 years is fairly low, 3.29%. Maybe she should see a kidney doctor, given the fact that the GFR is less than 40. But all in all, the likelihood of progression is quite low, as opposed to the same female with the same GFR and now has 5 grams of proteinuria. She has a 1 in 5 chance of going on to dialysis in the next 5 years. And so not only should she be seeing a nephrologist, but you should be talking with her about potential kidney transplant, talking with her about potential dialysis modality education in the future, a little bit of multidisciplinary care with dietitian, weight loss if they're morbidly obese. All of these become extremely important into caring for the patients. And so if we take the individual in our case, her GFR, this is the 40-year-old with 985 milligrams and 55 ml per minute GFR or stage 3A, you can see her 5-year risk is fairly low, 3.39, but that's with a really good GFR. And so it's really this albuminuria that's driving that risk. But even still, she should be recommended to see a nephrologist at least once to make sure that she's on the appropriate therapy. There's no indication for genetic testing in guiding the management of the patient with the team approach with her primary care provider. The nice thing about the kidney failure risk equation is not only will it just give the risk for the patient, but it will also give you, with appropriate guided therapies, what if you add this medicine, what is the improvement in risk reduction you would have? So for example, if you have good blood pressure control of less than 120/80, you can reduce the risk from 3.1 to 2.4. If you are on the appropriate antihypertensive with either an ACE or an ARB, you can again have about a 1% risk reduction. SGLT2s, a significant risk reduction at 5 years, almost cut that risk in half. And again, phenynerone, which is a drug for prevention of heart disease and kidney disease and type 2 diabetics, can reduce the risk for it by about 1%. And so it's a nice pictorial for the patient to see why you're putting on these medications. Why are you referring them to these people to give them the best chance? Again, most of these people will not progress to dialysis, but you're preventing their cardiovascular mortality as well. So what should you do for the patient? And I think the most important thing is that knowledge is power, that give the patients the tools, give them the information and empower them to be advocates for their own health. These are links. The Kidney Foundation has this campaign of Are You the 33, the 33% of individuals that are at risk for kidney disease. They can take a quiz online. And then there's also tools and handouts that are available through the Kidney Foundation that can be given to your patients in the clinic. I know in our office, patients get a CKD sheet every time that they leave. It has their stage on it with their GFR and ACR. I go over that kidney risk equation with them, and then any other subsequent information that I need them to follow up on, and all of that. So key points, kidney disease is common. It's deadly and underdiagnosed, not just deadly in the sense of moving on to dialysis, but again, I can't impart enough the importance of we're preventing kidney disease and progression for cardiovascular mortality, which is the vast cause of death in these individuals with kidney disease. Diabetes and high blood pressure being the two leading causes. So if you have these patients, that remembering the two most important tests you can get is an estimated GFR and urine albumin creatinine ratio, at least yearly. If they're abnormal, then perhaps you need to follow these more closely as you make treatment adjustments to them. And really having this classification and identification allows you to develop those that are at greatest risk and need the most follow-up and in-care coordination to prevent progression of disease. And really emphasizing the team approach. We as nephrologists aren't those that are caring for the vast majority of these 37 million. And most of them will be in the hands of family medicine and internal medicine clinics. And when you do need our help, we're here to help coordinate the care of the patients. But by all means, understand that a lot of the kidney disease partnership really falls in primary care. And I just added these as well. The KDIGO, which is what I had mentioned earlier, has these great top 10 takeaway quick handouts, and the links I think you should be able to get through. Mary should be able to give them to the National Kidney Foundation. But again, going through those heat maps and risks and what you should do in primary care for management of these patients. And in the same token, the International Society of Nephrology, again, has just very brief 2-page handouts for identification of kidney disease in primary care, and that this is a team approach, that it's not just we as the nephrologists, but that we're all responsible for the care of patients with kidney disease to identify, prevent, and then calculate their risk for best outcomes for our patients. And this is kind of a summary of, they put 2 together. Again, these are available at the isn.org website if you just type in early identification and intervention in primary care. So I will stop sharing here. I left about 10 minutes for questions. If anyone has any questions for me, I'm happy to answer them.
Hi, my name's Donna and I'm a case manager with Populance, but recently we had a patient and I went back into his chart to look at his numbers, but he actually had a normal eGFR. So going back 4 years, it was most recently 97, so that was good. But the one thing was that his his uACR for the last 4 years was over 756.
Mhm.
And then let's see. And so his eGFR was stable. And then yeah. So I was just wondering, the one thing he was being followed by a nephrologist, but what was interesting was that they prescribed a medication, Corindia, which I guess helps with kidney disease, but also cardiovascular. But the
Mhm.
problem was the physician had not listed on his chart that he had a diagnosis of chronic kidney disease. So we had to work backwards. So I guess providers
Yeah, so
knowing that listing the appropriate diagnosis for medications to be approved is important. So that
absolutely.
I'm learning
Yep.
myself with all of this. And then also his A1C, he was type 2 diabetic, but the range that wasn't really that high either. It was
Mhm.
6.7 to 7.5. So really his uACR was the number that was out of whack. Everything
Yep.
else was on that your grid there, fell into,
Mhm.
I'll say, the normal range, so to speak. But
But
so
he would still be defined as chronic kidney disease. He would be
mhm,
you said his GFR was 97, so he would be a G1A3. So
mhm,
by definition, he has chronic kidney disease.
yeah,
So you can, depending on how specific your EMR is, you could write CKD stage 1, or you can actually pull out CKD stage 1A3, and put that risk identifier on there. And I
mhm,
think that's one of the most important parts of this talk, is that I think for a long time everyone was falsely reassured with the GFR, and that was only one part of the puzzle. It's definitely important, but it's not the only thing. And so anyone that has proteinuria over 300 milligrams, you have to understand and identify the why. Is it just diabetes? Well, maybe not if he's had A1Cs that have always been less than 7. Now, there's a chance that, right, that maybe we missed a time when he was uncontrolled, right? Before he was in good care and things like that, which is can always be the case with type 2 diabetics. But maybe there's something else going on. And seeing a nephrologist. I think the finerenone or Corundia that you mentioned is great. Those are only approved for diabetic type 2 diabetics with CKD. I would argue that I would hope in addition to that, that patient is also on an angiotensin receptor blocker or ACE inhibitor, as well as SGLT2, because the data for prevention and cardiovascular risk reduction is much greater in those drugs than finerenone.
Hmm.
So it's kind of like a stepwise approach, right? You know, you have all these tools in your toolkit. And so, making sure that they're on ACE or ARB plus SGLT2. If they're still not controlled from a proteinuria perspective and you have room with their blood pressure, adding on, the finerenone is great. The other one is, and again, this wasn't this talk, but GLP-1 receptor agonists, aside from just weight loss and glucose
Hmm.
management, there is a definite risk reduction with kidney disease progression as well.
He was on those medications. And then just one other question or comment is that you had mentioned in the talk that a lot of these patients are managed by primary care providers, but at some
Mhm.
point they should be referred to a nephrologist. So as we know, access to specialty providers is limited. So, do you foresee, like, with these new guidelines and things, like a patient getting into a nephrologist might take a little bit extra time? And thank you for the talk today.
Oh yeah. So yeah, I think one is I think we're gonna, as we all get better at identifying these people, right? I think that's where the risk calculator becomes really helpful. If you risk calculate an individual and they're still considered low risk at 5 years, I think that's someone that you put them on the right drugs that they're supposed to be on. If things are stable or getting better, great. If they're not, or getting worse, or they're in one of those higher risk categories, those are the people that you need to focus on, getting to nephrology first. And again, um, once they're stable, once you have them on all the right drugs and you've stabilized, you may not resolve the proteinuria. And in most cases, you're not going to resolve the proteinuria. But you are going to identify people that, yes, they're a diabetic, but they have other indicators that maybe this isn't diabetes. And we can do a kidney biopsy to identify that. We can do genetic testing. And then, get these people into the right hands of, if they have a rare genetic disease that they potentially could be in a study for a new drug. Other treatments. I've had patients that are referred for me for CKD and it was presumed diabetes, and I'm looking at the labs and things just don't look right, and I diagnose myeloma often as a nephrologist. Amyloidosis is often diagnosed by nephrology. Lupus is often diagnosed by nephrology, and so that's where the puzzle doesn't always fit. Like, this patient has well-controlled blood pressure, they're not obese. Yes, they have the diagnosis of diabetes, but their A1Cs have always been great. Am I missing something? Those are the people that should, use the resources first, and then sort of go from there. And I think the National Kidney Foundation as well, with these heat maps that they have for actual data in Michigan, where are the areas that have the greatest risk that maybe they're not even on the right drugs. So many people aren't even on ACEs or ARBs or aren't on SGLT2s, and getting the focus into education to those populations is extremely important as well. Any other questions? And thank you for the question.
I just wanted to add, thank you so much for this talk. I always learn so much from you, Dr. Henderson, even though I've heard it before. And I do just want to let you all know we have 4 more upcoming sessions. So some of them will focus, a little more extensively on the medication management side of it, as well as some lifestyles and nutrition. So I put the link in the chat if you're interested in signing up for any of the additional sessions. But please join me in thanking Dr. Henderson for today's talk. Really fantastic.
Well, thank you very much, Hazel. Have a great day.
Thank you.
Bye.